Hi, I'm Dr. Amy Compton-Phillips, and I'm absolutely delighted to be here today to talk about our journey of how the Providence health system has helped navigate this year of 2020 with the pandemic. It's been a challenge. So just a little bit about Providence, which I'm sure you already know, but just a little level setting, is that we're big, right? We go all the way from Alaska down to Orange County in California and as far east as Texas, and span 51 acute care hospitals, 1,000 medical offices, 24,000 doctors, 120,000 total employees. And so when things hit us, we have both the tools, capacity, and resources to both think big but act small and make sure we're caring for each and every one of our communities. And that's really what was put to the test starting this year. And so I just want to walk you through a little bit about how we've navigated that path of how we first dealt with COVID, how we've been dealing with it and are at the moment, and how we're looking to the future to say that we really need to think about the world post-COVID and how healthcare can be better and how it can actually accelerate us on the journey that we know needs to happen to make health and well-being across the country ever better. And so just to kind of take you back to where we were, we had, as most of you know, the first patient in the U.S. with the novel coronavirus back on January 21st. I remember the day well when I got the text saying, hey, we have a patient that's been in Wuhan, China, and has symptoms and has just tested positive from the CDC. And that was a wake-up call. The good news is we had been planning because we knew back from the days of Ebola that a novel pathogen was a possibility. And we had been planning for if one happens. And our Everett Hospital was absolutely ready. And in fact, they handled it, the initial patient, with Ebola level precautions, right? And then we got more patients. And then we had the second set of patients coming in from that cruise ship. Remember that cruise ship that docked in Oakland and patients ended up positive? And they got brought to our Spokane facility that, again, was ready. They knew what to do. They knew how to navigate these patients. But as we started seeing patients come in, we realized this could be bad, and we had to actually activate our systems to be ready for it. And so we started an emergency operations center. By the next day after that first patient, we actually implemented changes in our electronic medical record across all of our physicians, across every single one of our ministries, so that every patient was being screened for travel and for symptoms to make sure that we weren't having unidentified spread in our communities, which was a pretty amazing feat to do across our entire footprint, in a day. But then as we started getting more and more, we realized this could get overwhelming for us pretty quickly. How are we going to triage, test, and treat everybody who needs it? And so we started doing things like saying, let's leverage the tools of today, not only the tools that that they used in 1918 with masking and social distancing and hand washing, but what are the tools of today that we can use? And then we started saying, oh, but it's not just the tools to triage, test, and treat patients. We're actually not going to have people in the places where they need to be, and we're not going to have the products, the PPE and the respirators, the ventilators, and we're not going to have the staff to actually man those ventilators, and we're not going to have the places, the space to put them. What can we do to convert storage rooms into ICU beds, right? So we had to really start thinking outside the box. And then as we kept going, we started saying, eventually this is going to end. What are we going to do next? And so we've been working really hard to continuously stay ahead of the game because we know that planning is the antidote to panic. And what we had to do as a system is make sure that our caregivers, our people, and our patients were not affected by a lack of planning on our part, that we needed to keep people safe and needed to be here for them. And so just a little bit about the navigation through that initial triage, test, and treat patients, because it was something that was a little different. It was asset-based thinking, saying, we've been doing a lot of work in our digital and our telehealth space over these past few years. If I'm a patient, and this was back in March, right? So put yourself back, a decade ago, whatever that is, 6 months. And if you think about it, the fact that we said, what if you Google on, do I have COVID? What's going to come up? And what we said is we want to have an answer for people if they Google on, do I have COVID? And so we worked with Microsoft and built a chat bot that allowed people to kind of go through their symptoms. Do I have a cough? Yes. Have I traveled? Yes. You might actually need an appointment. Would you rather do an Express Care virtual appointment and get a telehealth visit, or would you rather go in and see your doctor? And so we built this branching logic very quickly on. And by the way, we worked on Microsoft with that and said, we don't want to just build this for us. You're welcome to take it and use it whoever. Microsoft ended up sharing the technology behind the chatbot with the CDC, and numerous organizations by summertime were using the tool, and now it has many millions of hits on that chatbot. So it's kind of cool. But in addition, it funneled many, many people into our Express Care Virtual, our telehealth visits for patients, which again, back in March was kind of a novel thing. And in fact, in 2019, we had done 70,000 telehealth visits within Providence. By April of 2020, we were doing 70,000 telehealth visits a week within Providence. So a year versus a week. So we rapidly scaled. We were able to actually use this infrastructure to create tools to help people in the way that they needed. Which was incredibly useful. The other thing that we did is we said, okay, not everybody that has COVID needs to be in a hospital. And so how can we make sure that if you're not all that sick, if you're not at risk of respiratory compromise and we think you're going to collapse because your breathing's going to go badly, then we actually set up a monitoring program at home. And I'll give you some stats on that in a little bit. But it was really kind of thinking about how do we take the many tools that we've been building over the past few years and actually use those tools to really transform care delivery in a way that we have to have it transformed immediately. So that was the silver lining that we've seen. The pandemic playbook was really pretty awesome because the triage, test, and treat framework was very much in the clinical space about how do we make sure we take care of every patient in front of us. The pandemic playbook that we built that helped look at where are our people, where are our products, and what places can we treat those in, was very much about operations. Do we have the tools? Do we have the infrastructure to do it? And so that made sure that this was both a clinical and an operational process for us to stay ahead of the game. And the good news is, knock on wood, because we're not through this yet. We never actually ran out of PPE, even though it was a risk, but it was because our supply chain people dove in and were doing the work to not do that. We started working broadly with coalitions to make sure that we had ventilators everywhere across our footprint. And oh, by the way, let's work with a consortium of people who need ventilators, because we also knew that COVID, the pandemic, would be lumpy, and assumed that it wouldn't happen everywhere all at once. But while it's going up in Seattle, maybe it's negligible in Montana. But then while it's going up in Montana, it might be negligible in Seattle, right? And so how can we actually use our footprint to our advantage so that we can smooth and streamline things through appropriate sharing? We also knew that we were in something new, and that if you're in something new, you have to actually figure out what you're doing. There's no answer on the shelf that you just pull down the playbook and read it about what's going to happen, right? You have to figure it out. And that's exactly what the scientific method is about, and that's what innovation is about. And so we decided early on we were going to have to support the tools that were going to allow us to science our way out of this mess. And those tools include really important things like clinical analytics. We have to actually know how we're treating patients and how they're doing if we're going to want to continuously get better, because better has no limit, and we're certainly not there yet. We needed to actually not just implement telehealth, but optimize the tools and the capacity that telehealth has to move knowledge, not people, because that's what we want to do in the future world, and it's what we had to do during the height of the pandemic. And now, by the way, we're revving up because who the heck knows what's going to happen this fall and winter. And then last but not least, we had to double down on our research capacity, because we knew that, again, without answers on the shelf, you have to sort them out. And just to kind of go through each of those in turn, clinical analytics, fortunately, we had done a lot of work, again, building on our vision of Health 2.0, of where we've been trying to modernize, simplify, modernize our IT infrastructure. We had been putting a lot of data and information into the cloud that frees up our ability to do analytics on it. And so literally, like on day one, with our first couple patients, our chief medical analytics officer started working with our information systems group, our IT group, to say, how do we actually make sure everything that we do is put into an effective data mart so we can study and learn from it? Because that's going to help us not only learn fast on how to treat patients, but to start actually moving upstream and predicting what's coming. And the good news is that's really worked. And in fact, we've built an entire data set, a data infrastructure that's guiding all of our decisions on treatment, on prediction, on how to move those supplies around for when you get a surge in one area, not in another, around where we might need bumps in testing capacity, which we need more everywhere, but about ventilator status, about everything you can think of. And so just a few examples of what that looks like. And it's got a fantastic acronym called COVERED, and I wish I knew what it stood for, but I always forget. But it's the COVID virus registry. But the COVERED database, just at a snapshot, if you just click onto it, shows the current status of how many people do we have in the hospital right now. And I still am in the habit of checking this every day. And it's really kind of helpful because it kind of sees the waxing and waning that we've had over time. But even more importantly, it shows us how we've been doing with that trend over time. And that first few months, it was really remarkable and incredibly distressing, the fact that a quarter of the patients that got admitted died. Right, and that we had a huge percentage of them were put on ventilators, and that they skewed older. But that as we noticed over time, we started finding that, oh, the mortality actually has been going down over time. And so in the first tranche of patients, the first 750 patients, you see that the mortality was around 24%. And by the second tranche of 750 patients, the mortality went down to 18%. And you also started seeing just differences in some of the treatments, and so using less of the ventilators, because we learned from China and from Italy to intubate early, and we learned from experience in our system to intubate late and actually use a lot of ventilator sparing high flow oxygen type therapies, right? That came from studying and learning our actions. But then over time, we also started seeing continued improvements in mortality and started seeing shifts in the demographics. Our patients started getting younger and they started getting browner, that we had more people of color and younger people of color. And we still don't know exactly what this is. Our hypothesis is that people of color are more likely to be essential workers, that we're not able to socially isolate and work from home. But we do know that it's definitely an ongoing trend. And we did continue to see continued decreases in our mortality, which is great news over time. But this database has allowed us to continuously test, try, understand, learn about how to improve things. And then we've been sharing those learnings through our great, expert to expert collaborations through our grand rounds. And so every week we have grand rounds that share, this is what we're doing, this is what we've learned, here's how we optimize treatment in the emergency room, here's how we optimize treatment at home, here's how we optimize a virtual patient visit, here's how we optimize ventilator care. And by doing that and by having the data to say who's doing really well, let's learn from them, we've rapidly had this continuous cycle of improvement, which has been actually invigorating for the clinicians that we have to help deal with an otherwise just untenable situation. Telehealth, you heard me talk about already, the fact that the going from 70,000 a year to 70,000 in a week was unprecedented, and definitely blew all of our assumptions about how telehealth could be used out of the water, which is not unlike, by the way, what's happening in the rest of the country. But the really interesting thing is we don't consider telehealth just a visit with an individual patient and their doctor. Right, that is one application for that kind of retail transactional experience of a patient visit. But we also have physician-to-physician consultation, so that in communities that don't have hospitalists, for example, we're supplying hospitalist care or stroke care or behavioral health care, which, by the way, has just exploded during this pandemic because so many people are stressed and depressed and lonely and isolated, or using substances to cope with the loneliness and stress and isolation. And so our behavioral health program has dramatically shot up this year, as has our treatment at home program, which, I mentioned the COVID treatment. We now have had about 10,000 patients in our COVID at home plan, where we have banks of nurses monitoring patients who are tracking their oxygenation status and their temperatures at home while we try to take care of them where they're more comfortable. And in doing so, by the way, we've saved a huge amount of PPE, right? And a huge amount of distress for patients that are isolated from their families getting care in the hospital, because trying to minimize the risk of transmission. And so it's better for patients, it's better for the system, for people to get care in their home if they're medically safe to be cared at home. And by the same token, we're actually doing a ton of work in our ambulatory sites. So we rapidly turned on the ability to do visits at home. And by the way, do it in a way that gets doctors paid for that care, because we know that we have to preserve people's ability to provide care, which means they have to make their mortgage and pay for their internet connection. And so we're trying to do this in the right way and that's intelligent, but it's not optimized. And so now we're working on optimizing the workflows to make it ever seamless and easier, because fast isn't always optimal when you turn it on. And the other area that we're working on is rapidly scaling up acute care. And that acute care is really interesting because many of you have seen what they're doing with hospital at home or medically home companies that are getting huge amounts of investment to take care of inpatients, but inpatients at their house, right? And you can do that with remote monitoring and tele-ICU functionality and home visits with nurses. And so now we're in the process of rolling that out as well, because again, if people can get care at home, many, many people would prefer that. In the same token of being able to respond to all the pressures, we also have to recover, and we actually have to say, let's take care of everybody, not just our patients that have COVID. And so one of the things we did very early on in May is we said, okay, right now we're in the thick of this, we're in the middle of it, but we know we're going to come out on the other side. And then because we know that this germ is going to be around for a while, we've got to make sure we're navigating and dealing with it along with everybody else. And so we started planning on how do we manage the work with not only COVID itself, but also all these other crises that emerge concurrent with COVID, the crisis in social justice, the crisis in the economy, the crisis in the climate with the wildfires, right? We've got to navigate all this at the same time. And so one of the things we have to do is make sure that we're really thinking ahead and planning and predicting the future and leveraging science and leveraging research so that we can have tools in our toolkit to be ready for it. And so we've absolutely been doing that with analytics, with research. Our Providence Research Network has been just honestly unbelievable at coming together saying, let's work rather than individual research organizations. Let's see how we can be better together through turning on clinical trials all at the same time. Let's work with our health services research. Let's work with partners in the research industry so that we can aggregate information very rapidly, so we can get it out quickly, so that we can learn faster, so we can get on the other side of this crisis more rapidly. And so just have just unbelievable thanks to the researchers that have been collaborating across the Providence Research Network, together with researchers, by the way, from many of the elite research institutions, both here in the US as well as abroad, that kind of synergy has been absolutely remarkable, and I think is something that we're going to be building on for many years to come to show what's possible. And last but not least, planning on what's ahead. We know that this is going to be an interesting flu season coming up, that it would be wonderful if what happened in the Southern Hemisphere happened in the US, but what happened in the Southern Hemisphere, where they actually basically eliminated flu because it was during the strictest part of the shutdowns in the early initial phase of the pandemic, and people were being very responsive and just staying home, right? And so flu just didn't spread in the Southern Hemisphere. Our worry is that we're a little bit over that strict part of the shutdown now. People are out and about, and people are wearing masks, great, but they're back out, interacting with each other, and they're in schools, and they're not all masking when they're in schools, and there's no mask mandate, which means that the conditions for actually having a resurgence of flu are possible and could happen at the same time as COVID. And so we're actually, thinking again very hard back to our pandemic playbook, planning for a worst case scenario. We're actively working also on saying, how do we manage not only flu vaccines, and so we're on a path right now, working to get 100% of our people vaccinated for flu, but also planning very clearly with distinct work streams on logistics and on tracking and on distribution and on prioritization on how to get a COVID vaccine distributed out as soon as one is available. And so we're going to have all the pieces in place, everything from -70-degree freezers to tools that allow tracking who's been vaccinated, so that we're going to be ready on day one as soon as the vaccine is actually produced. And because there's a lot of options out there. So while 2020 has been just a year that I think probably every single one of us is excited to put in the rearview mirror, the silver lining of everything that has happened, because 2020 was the year that it was, is that somehow we've been able to take what has been a bad series of circumstances and demonstrating to the organization, the people of Providence, the people that are affiliated with Providence, the people in the communities that Providence supports, and the patients that we take care of, that somehow better is really together, and that we can actually, if we do this in the right way, and we're thinking clearly, and we're depending on the science, and we're focused on what's possible because of the science, that we really can execute on our path of getting into health for a better world, despite the fact that the world is sometimes a little crazy. So thank you so much. I very much look forward to staying in touch and answering any questions that you might have.